I'll just briefly brush up what we studied in the last class and we'll continue with this. So last class we have started with the drugs acting on peptic ulcer. So what are the different classes of drugs we have studied? Drugs which neutralize the gastric acid, that is antacids, systemic antacids, non-systemic antacids. In non-systemic we have buffer type, non-buffer type. So in miscellaneous we have alginates, samethicillin. Okay. So drugs which reduce the gastric acid secretion can be H2 blockers, that is cimetidine, ranitidine, roxetidine. Except for cimetidine, we have lesser side effects with other group of these drugs and well tolerated drugs even at 5 times the therapeutic dosages. So anticholinergic drugs we use it in refractory cases. Okay, so propantheline or spinonium, which are M3 blockers, pyrenzapine, tilenzapine, which are M1 blockers. Prostaglandin analogs we have Misoprostol, N-prostine, which are PGE2 analogs, which promote the gastric mucous membranal protection. Other mucous protectors are, okay, we have sucralfate, colloidal bismuth substrate, ranitidine. Also leading drugs we have carbamazepine, and anti-H-choleric drugs we have this amoxicillin, clarithromycin, tetracycline and metronidazole. So PPIs, do you know PPIs? So PPIs are omeprazole, lansoprazole, esomeprazole, pantoprazole. All these drugs are there. So briefly, so how was our gastric acid secretor? Initially we have this parotid cells. You can see 3 receptors there. Okay, the 3 receptors here are M3 where acetylcholine is coming and acting, histamine is acting, and also our gastrin. All these are helping in promotion of the gastric acid secretion, either by increasing the calcium level within the cell or by activation of the protein kinase. So we have our vagus nerve here. Okay, you can see the postganglionic fibers of the vagus nerve. They can release acetylcholine. Okay, so once the acetylcholine is released, they can act on this parotid cells. They can also act on this ECM or enterochromatin-like cells, where they can release the histamines. You can also see that they can also go for action of the G cells and D cells. Okay, so G cells, how they are acting? They are promoting the increase in gastric acid secretion. Okay, so on the D cells, how they are acting? They are helping in negative feedback inhibition. Okay, so this D cells are the ones which are having this feedback inhibition by the action of the luminal side hydrogen ions. You can see here. Okay, so this luminal cell hydrogen ions, their levels can alter the somatostatin levels, and somatostatin, this has the negative feedback there. Okay, so this has negative feedback on this gastrin. So this negative feedback is inhibited by our vagus nerve. So this is in brief. Okay, the first part what we are seeing here is the antral and the frontic part. So here we saw how dextrin is produced. Okay, so by the influence of all this gastrin, histamine, okay, what had happened? The this hydrogen potassium ATP system is activated. Once it is activated, it can actively separate this hydrogen and the chloride which comes to the chloride channels. The bicarbonate ions which goes to the basic side, they can act as the barriers for the acid. So antacids, you need to remember, that is mucus, bicarbonate, prostaglandins. These are the 3 defense mechanisms. These are promoted with the help of our antacids, and they do not neutralize or do not prevent the overproduction of the acid. Okay. So you got to know that the acidity environment, if it is decreased even by slightest level, the gastric acidity, once it is reduced, there is less and lesser chances of getting the peptic ulcer. So coming to the systemic antacids, we got to know that it was a classical drug was sodium bicarbonate. The first point was with the promotion of this bicarbonate ions, but the negative point what we saw was accumulation of the sodium, which would increase the tendencies for hypertension and also worsen the congestive cardiac failure. So non-systemic antacid buffer type, where we use two drugs, okay, magnesium and aluminum salt, magnesium causing diarrhea and aluminum causing constipation. So when these drugs were used together, we had the beneficial effects on the regular thing, that is the bicarbonate, because all these things is there, promotion is there, and we also prevent the gastric acid formation, and potential liver is also formed. So aluminum salts, they are used along with the magnesium salts. So coming to the non-systemic antacids, non-buffer type. So non-systemic antacids are better in that they are less absorbed and they are non-buffer type. Okay, that means we are not using one drug counteracting the other. And the positive point about this is they have lesser side effects as they are less absorbed. And the other positive effect what they tell is they can act as a calcium supplementary agent in pregnancy. But if it is used for a longer time, then hypercalcemia, kidney stones, all these things can be there. So coming to one more antacid, that is samethicol, okay, silicon polymer under water and colloid. What it does, it decreases the surface tension, thereby reduce the bubble formation. Okay, it acts as a foaming agent. It is used for belching, hiccups, okay, flatulence, all these are used. And this samethicol, as it is water and colloid, and it is used for bed sores also. So sodium alginates, hydrophobic colloidal carbohydrate, okay, how it helps is, it is again helping in the formation of a protective layer on top of the gastric meninges, where acid floats on this layers. So oxytocin, it is again combined with these antacids and acts as a surface anesthetic. So antacids, you got to know, aluminum drugs, constipation is there, calcium, venous stone formation is there, magnesium can cause diarrhea. Okay, so calcium carbonate releases the carbon dioxide will be there, which will go for belching and carbon due to carbon dioxide exposure. So to the H2 antagonist, you got to know that in the H2 antagonist what has happened. Here we are acting on the histamine receptors, okay, histamine receptors. That means you just imagine the diagram which you have put on the first state, okay. So we have three components there, gastrin is there, histamine is there, acetylcholine is there. So only one part of it is prevented, that means nocturnal part we are concentrating on when we are using this part. Okay, it is relatively milder compared to our proton pump inhibitors. So we will be studying it why it is milder. Okay, so modest impact on the gate stimulator. That's what we mean by using it in the night time. Okay, gastric acid can be secreted under the influence of Vegas and also by under the influence of this food particles. Usually get dietary peptides, what they do on the luminal side, you saw there was a D cell and one more was a G cell. Okay, so G cells they get stimulated with the help of this dietary polypeptides. Okay, once these stimulate, this gastrin is produced. Gastrin again it stimulates the chain of reactions. So good overall absorption, better bioavailability. Okay, so even though they cross the placental barrier, there are less chances of side effects. They are all both in the form of tablets. Ranitidine injection is available, ranitidine tablets, 150 milligram. Okay, injections are available at 75 milligram per ml. Okay, we can use this. We can use it most of the conditions. Okay, so duodenal ulcers, gastric ulcers, GIT, during the Relson syndrome, and prophylaxis of aspiration pneumonia, and H2 blockers, though they are called H2, they can also help in the other allergic reactions which primarily involved with H1, that is urticaria. So H2 antagonists, but per se they do not have that much side effects, but the first drug, similitude, we saw that it prevents the conversion of androgens and metabolized position of estrogen is prevented, gynecomastia and impotence is created. So similitude is the enzyme blocker, so or enzyme suppressor, where what will happen? The drugs which are used along with it, they tend to be increased, which are hepatically metabolized, maybe warfarin and some other anticoagulants. So H2 antibodies, we need to take care of smoking. Okay, used in patients with caution and disorientation. This is prominently we are telling with respect to similarities when it was used intravenously, that there was because of mental disturbance. So we know that antacids and vanillin, they should not be used together. Okay, one will suppress the absorption of the other. So coming to the next group of drugs, it is proton pump inhibitor. So we saw that the final step of this gastric, the step of this protein kinase, histamine, okay, all these were to activate this sodium potassium ATP system. So we are now concentrating on the enzyme which on the drug which directly blocks this action. So direct blocking of this drug, this system means by any mechanism the acid will be secreted by, it may be by the food stimulation, it may be by the mental stress, any mechanism. The final mechanism here was to stimulate the sodium potassium ATP system. Once we block this, okay, all the pathways are inhibited. That means nocturnal, early morning, meal stimulated, all type of gastric acid secretion can be prevented. The negative point about our proton pump inhibitors are most of them are shorter acting, but we have a positive point about this drug, that is they are binding into this and sodium potassium ATP system irreversible. So irreversible inhibition renders this sodium potassium ATP system inactive completely. So after 3 or 4 days, what will happen? There will be complete blocking of this action. Okay, complete blocking of most of the sodium potassium ATP system which is present in the gastric and the duodenum and further mucosa. Okay, so most of it is blocked after 3 to 4 to 5 days. That means there is initial biological lag for this drug to act. So we can start with the antihistamines and later shift over to this. We can use them concurrently. Early morning PPIs and evening we can go for this H2 blockers. So how this act? Okay, so we need to remember proton pump. What is this proton pump? Okay, this hydrogen ion constitution pump. There okay, for the axial production, that we call it as proton pump. Here one small mechanism we need to understand. This these proton pump inhibitors we are providing in the form of entry-coated tablets, and this should not be disintegrated in the stomach in the acidic environment. We are putting it in a form that the outer capsule get dissolved in the alkaline pH. That means once it enters the duodenal part. So once it enters the duodenal part, the coating is removed. Okay, the entire coating is removed under the alkaline pH, and these drugs can be absorbed into the cells. So once this is absorbed into the parietal cells have the acidic pH. Okay, so under this acidic pH, what will happen? The drug get protonated. Okay, so the parietal cells release the positive hydrogen ions during the acidic production, and this protonated PPI, okay, what it gets accumulated more and more into the parietal cells, and there is something called as resistance as a batch trapping. Under the influence of acidic environment inside the parietal cells, okay, the drugs can get trapped. Okay, once this is trapped, the action of this PPI is taking place. How it happens? This PPI's active entity is sulfonamide. Okay, this active entity sulfonamide forms covalent disulfide bond which is irreversible. Okay, and once it is irreversible, there need to be fresh synthesis of sodium potassium ATP system so that the further acid production should occur. So even though they are shorter acting, like half an hour, 1 hour, 2 hours, because of this irreversible blockade, their action can be there for 40 to 70 hours. That means 3 to 4 days, the action will be there. So universal binding of this sodium potassium ATPase, what it does, it prevents the movement of the hydrogen in the polysaccharide cells. Okay? Hydrogen ions are not pumped out, and there will be inhibitoria and gastric secretion is blocked. So in order to return to the normal action, there should be fresh production, and it takes a minimum of 18 hours for the fresh production of the sodium potassium ATPase system. So here is a in brief, okay, this diagram is more appropriate for understanding all the mechanism of action. We can see there are, first we have completed this cimetidine, okay, cimetidine or the ranitidine, what it does, instrument block is there, okay, instrument release is blocked. What can happen there? There is no conversion of ATP to cyclic AMP, so cyclic AMP it is not activating our protein kinase. Whereas our vagal nerve which produces this acetylcholine and gastric, which is again both are increasing the calcium levels, okay, that can be prevented with the help of this pyrazine, okay, pyrazine, thiazolide, oxygen, all these drugs can prevent that, okay. Anti-muscarinic drugs, they can act there, and we can see that our omeprazole or the proton, it is blocking the final phase, that is our proton pump. So we also have the drugs such as Misoprostol, which can act on this prostaglandin receptors, okay, and they are analogs, okay. So that means the prostaglandin levels are increased, and we have this gastric blocker also, gastric, that is protonamide. So coming to the therapeutic uses, similar to our H2 blockers, but they have more perfect action. Okay, so that is GRD, we can use erosive esophagitis, then go for duodenal and gastric ulcers, Zollinger-Ellison syndrome, Barrett's esophagus, most of the conditions we use them, and it is also part of our H. pylori induced ulcer treatment, where we use triple therapy. So side effects, most of these drugs are not having major side effects, that, and they are also safer in pregnancy, but they are not prudent, and most of the gynecologists, they are using this omeprazole preparations because of this. One incidence is that though we go for this doxylamine, this is also given as an added treatment. So side effects are less, but still some side effects we can expect. Okay, because of this gastric decrease in the gastric acidity, they can decrease the absorption of this, the ketoconazole decoxin, that is there. So pharmacokinetics, one thing we need to remember, food disrupts its absorption, so we need to take care that it is used before food. And one more thing we need to remember is this drug is blocking this sodium potassium ATPase system. That means the sodium potassium ATPase system should be exposed. Okay, so when the person is having empty stomach, only 10% of this system is active. That means if you are giving it in an empty stomach, only 10% is active. So how do you prevent most of the sodium potassium ATPase system which is present in the DNA? That is by after half an hour you take the food, okay, after half an hour or 1 hour you take the food, and because of this food there can be increased gastric acid secretion, and the dormant proton pumps, they can also get activated, maybe like 40% to 3% like that. So that's why it takes a longer time. A biological lab is there, and you can see the action only after 4 to 5 days. So they are irreversibly inactivating, though you have told this point, 1 to 2 hours, but still the action will persist because of the blockage, and full proton synthesis it will take minimum of 18 hours. So concomitant use of this H2 blockers, what it can do. So there will be tendency like, because this drug is acting after 3 to 4 days, can we use this along with the H2 blocker so that the action can be announced or immediate relief to the patient can be given. So this can be practiced but at different times. Okay, as you got to know that the proton pumps at the empty stomach, they are only 10% of them are active, and if you use this anti-H2 antihistamines which are immediately acting and there is immediate suppression, what can happen? Less than 10%. That means the active proton pumps may go up to 5% or less than that, where our drug becomes ineffective. So concurrent usage, it should be prevented at the same time. So antacids at different times, H2 blockers at different time, or this proton pump inhibitors at different time. So better to go for 2 agents, not for 3 agents. So one enzyme inhibition action is there, they can inhibit CYP2C, so you can prevent the metabolism of some of the drugs you can be given together. So minimally excreted kidneys, so no problem with renal disease and in elderly. So adverse effects, they can be rebound phenomena that you need to remember after long usage. They can be increased gastric secretion and it may lead to gastrinomas or carcinomas. That is one of the rare complications when it is used after more than 8 weeks or more than 2 months. And leukopenia, hepatic dysfunction, most of these, and liver deficiency, most of these are the side effects which can be expected after prolonged use. So we have seen that patients once they put on this PPIs after food, okay, if the patient is taken some coffee or that, so immediately that vomiting sensation will be there. So GI disturbance problems initially it can be there, nausea will be there. So sometimes it can lead to constipation and or diarrhea. So drug interaction, I told that was digoxin, ketoconazole, their absorption can be increased due to inhibition. They can be increased the level of diazepam, phentoin and warfarin. So coming to the anticholinergics, anti-muscarinic group of drugs. So we have this classical quaternary drugs, that is propantheline, oxycodone. We are not telling it as anticholinergic, better term is anti-muscarinic. First, we are concentrating here on the receptors which are present on the ECL-like cells, etochromatin-like cells, and also the parietal cells. Okay, so M3 receptors is the one which is mainly involved on the parietal cells. Okay, we saw that on the first diagram. Okay, so we are inhibiting this M3 receptors with propantheline, oxycodone. Parasympathetic inhibin more on the M1 receptors. Okay, so they are used in refractory cases. So we already know how this action takes place. Okay, so once the receptors are blocked, there is no production, there is decrease in production of the histamine. Okay, so because on the blocking of the ECL cells and also decrease in the gastric action. So gastric action, histamine release, both are prevented. So further, there is no increase in the serum calcium or no action on the protein kinase system. So protein kinase is not activated. Further downstream event of sodium potassium ATPase activation is not there. So as with any other cholinergic drugs, what we can get, anticholinergic drugs, what we can get, blood vision is due to sacrificing effect is there with the longer acting drugs. So that we can just put it as Vidyas's maybe to accommodation. Okay, and drug, you know, most of the patients who are having these GI symptoms, they come with the symptom of drug. And if you use this drug, again the symptoms may increase. So these are some reserved drugs for refractory cases. So Misoprostol, analog of PGE2. So you got to know that prostaglandin, it is having an effect on this gastric secretion. Okay, so what will happen once this prostaglandin is given? So prostaglandin analogs are given, they can act as a protective layer, and the secretion of this HCl are both the actions are helpful. Okay, so inhibit the cyclic AMP, inhibit the secretion of gastric acid, and stimulate the secretion of glucose and bicarbonate. So prostaglandin mediated vasodilation is there. Okay, so once more and more vasodilation, more and more mucus production is there, and they are helpful in gastric ulcers induced by NSAIDs. Why it is so? NSAIDs act by what happens with COX-1 inhibition in the GIT? COX-1 inhibition, prostaglandin, prostacyclin mediated gastric acid production is decreased. Prostaglandins are the natural protectors of the gastric mucosa. So they are directly acting on the antagonist action of this NSAIDs. So that's why it is helpful there. So they are less effective than H2 antagonists because the production part is prevented, but action HCl production is not decreased. So the drugs which decrease the action HCl production, they are more effective, and they can cause diarrhea, colitic pain that can be there because of prostaglandin mediated increased intestinal motility, and in case of pregnancy, we need to avoid these drugs as they can go for uterine contraction. So coming to the mucosal protectives, okay, so antacids, they produce a layer around the gastric mucosa, and this mucosal protectives, we primarily use them in cases of ulcers where we need the protection for this eroded gastric mucosa. So what they do? So they are viscous and form tenacious base with water and acidic solutions. Okay, and they are covering this ulcer layers for at least 6 hours once they are used, and they can go for release of prostaglandin, and once prostaglandin is released, prostaglandin mediated vasodilation, more and more mucus production, all these things can be there, and they can inhibit the H. pylori action, okay, by blocking this ulcer surface. Colloidal bismuth substrate, again one more mucosal protective. What it does, again bismuth can coat this ulcer layer. Bismuth is a can produce a black staining of this tongue. Okay, once there is black staining, the patient will think something has happened to him, and blackening of the stools may be there. Okay, so blackening of the stools can be differential diagnosis for our what happens in gastric ulcers. There can be bleeding, GI bleeding. Okay, once there is GI bleeding, there can be malignant. Okay, that part black stools can be there for this also. So we need to be cautious and suspective about this. So once it binds to the ulcer crater, coating is there, production of acid and pepsin, increased mucus secretion, increased prostaglandin, and helps in eradication of the H. pylori. So H. pylori, these are the scientists who got the Nobel Prize for discovering H. pylori. As much as like 90% of the duodenal ulcers, 60 to 70% of the gastric ulcers, they are associated with the H. pylori. So once it was discovered, we got to know that this H. pylori is a culprit for most of these ulcers. Initially, there was a slogan that no acid, no ulcer. Okay, now no H. pylori, no ulcer, like that. Okay, so initially the acidic environment or the HCl was made the main culprit, but now it is H. pylori as a main culprit. So how can we diagnose this? This H. pylori produces the urea. Okay, so urea blood tests are there, and we can go for endoscopy. Ulcers, craters can be seen, and biopsy is there. Okay, so in the diagnosis. So how it is able to live in this acidic environment? Because of this urea production, what happens, there is a protective coat of neutral zone is formed between the reaction between this HCl and the urea. So this protective coat helps in survival of this H. pylori. And more is the acidity, more virulent will be our H. pylori. So that means by decreasing the gastric acidity also, we can decrease the virulence of this organism. So eradication of this H. pylori, okay, so we need a drug which can directly act on this bacteria. We need a drug which can decrease the acidity. Okay, so ideally we go for 3 drugs. Okay, in this 3 drugs, there will be one proton inhibitor or ranitidine bismuth, where we combine a H2 blocker and also a mucosal protective. So we will be learning it in the later slide. So the bacteria which causes chronic inflammation, and it is involved in most of the ulcer formations. Okay, about 90% in the duodenal and about 67% in the gastric ulcer. So, and it is also a risk factor for esophageal and stomach cancer. How can we do this? How cancer can be produced? What happens due to chronic erosion? What can